You doing? Awesome, great, grand, right? So we're going to start lecture today as we have last couple blocks where we talk about anatomy stuff, and we talk about MSK radiology imaging, okay? Before we get to that point though, I feel like I haven't seen you guys in quite a minute, and out with some stuff myself, obviously, so I apologize for having to move the lecture yesterday. I appreciate your guys' flexibility and patience. Don't worry, we'll get to the awesomeness. Okay? We do have a saying in orthopedics that you have to be fluid because flexible is too rigid. Okay? So if you think about that, you're like, so I need to be more than just flexible, right? But I try not to put a burden on you guys as students as far as course materials. So again, today we're gonna slow down a little bit. We're gonna go through MSK radiology, some anatomy review, because I feel like it's been helpful for you guys. Do you guys feel that way? Yes? Okay. All right, we're at the point where we're wearing skull caps. It's getting to be that cool. That's awesome. So, but like I said, I want to back up a little bit and talk a little bit about the test, just because, we do go through the metrics of it, and the test performed well. Okay, but as I was just telling your class leader, not only did the test perform well, meaning it was a fair and valid test, because that's my thing, right? Fairness. But you guys perform well on it too. Okay? So the question becomes, if you guys are performing so well, do I have to make things harder? Okay. I don't think so either. I think what it is this is the results, right? The test results and the test analysis results. I think what they indicate is that we're succeeding in both being students and instructors, and how we discuss things and how we review things and how we not only recall things but synthesize information. You think that's fair? Okay. I hope you guys feel that way. If you have concerns, again, you're going to get that review at the end of the semester. But if you wait that long to tell me things, I can't be as effective. Okay, so quite a few of you have stopped me either in the hallway, right, or after class and said, hey, can we do this? And my answer is always, of course. Okay, as long as it's within reason and I feel like it's value added. Okay, so again, if you guys come up with something, let me know. Because the way this block is going to go, it's going to be very similar to the first block, just lower extremity things, correct? Okay, so it really shouldn't be a surprise. You guys got my blueprint now, right? You figured me out, okay? Some of you guys, especially in the back left over there, all right, you've been trying to figure me out, all right? It's like, all right, you figured me out. You know how I'm going to test you, you kind of know what I expect, and you realize that I am huge, right? I put a big emphasis on physical exams, correct? So you got to know them, right? Because what happens is you guys get out to phase 2 and you say what? I never learned physical exams. I don't disagree with that statement, but were you taught them? That's where I'm trying to be more effective in saying, well, you're laughing at me already? Yeah. I'm trying to be more effective about saying, hey, let's take some time and really slow down and talk about these things and let's understand them. Let's not just go through the motions, right? You guys all pretended like you knew what you were doing in clin skills, right? Yeah. And if you didn't, you wouldn't be here. Some of you got a little bit more than others, but hopefully, again, the level that we're hitting things at now, I'm hoping that you guys get a deeper understanding of why these physical exams are important. Because although orthopedics is only 8% of pants, what percentage is it of your daily practice in the military? 40 to 50% is the correct answer, right? So you will learn this. Some of you will just struggle because you'll wait too long to learn it, right? But this is important. I like the fact that you guys are smiling about that, right? Again, orthopedics tends to be one of those classes that people are like, I just got to survive it. But more importantly, you've got to be able to execute physical exams and be able to not only diagnose, manage, but also refer patients when appropriate, correct? Okay, now that I'm done talking, I've been talking for 4 minutes straight. So, what questions do you guys have about the test? It was so long ago, right? Ages ago. Okay. The question that I knew was going to get some people, got some people. Okay, the question about the zones and the finger, right? Okay, I mean, good gosh. If you go back and you think about the question, it says you see bone and no tendon. I need to take that out. That makes the question too easy, in my opinion, right? Because I'm telling you, there's no tendons there. So anything distal doesn't work. It's in the question. Yeah. Yeah, question. Let's see, I knew I was going to get a question now. That's correct. So the insertion is what you're thinking about, but is there a portion where the one tendon dips into the other? Yeah.
You said there's nothing in here.
Too easy. Too easy, right? It is what it is, but I'm just telling you, when you get questions like that, and I don't disagree with you, disagree. Yeah, yeah. And so the question becomes like, are you going to be doing those exams where you're looking into the actual wound, the laceration itself? Yes. So the question works on multiple levels because it gets you to think about when I don't see things or I do see things, I'm thinking things. Not just, he said on the slide that if it's in this area, then this is not going to work. Well, I don't disagree with that. But I'm just telling you, if there's an absence of tendons completely, nothing works. Does that make sense? Okay? So I think the test question is a valid one, right? Now, some of you will question the fairness of it. But it was definitely an upper level question test. Test question, excuse me. Upper level test question. So it was one of those things, it's like, are you just literally regurgitating what I told you to know? Or are you able to think about this critically and be like, well, wait a second. Does everything follow a picture in the book? No. Then that's real life. That's orthopedics in the real world. When you do your focused physical exam and you isolate the different joints, right, and you don't see things working, what is the basis of that? What is the anatomy? Remember I told you guys even longer ago, right, when we first started out, that orthopedics is something that I can teach you the course material, but I can't teach you to reason through it. Okay, and maybe I didn't say it like that, but I just want to get you guys to think. When you're talking about orthopedic stuff, anatomy is power, right? If you understand your anatomy, you have an advantage over the nurse practitioner. Right? Ooh, I said it. Sort of. But I'm just saying, like, you know, when you understand that the way you guys are trained, you're trained to really get into an assessment not only of the pathology, but also the anatomy that's involved. Make sense? So that's why I'm telling you this is a higher level of thinking. Okay? Good to go? Okay. Another question that came up, the question about the staph versus the pastorella multicida. Right? Again, it performed well, but I think the terminology kind of got some of you guys. Okay? You guys do understand that staph and strep is pretty much everything, right? Right? Gas, group A, streptococci, Hawkins, whatever. But then you have to think about what's specific to dogs and cats, right? Why do I get you to think that way? Because here's the thing. If you give somebody that has a strep or a staph, not MRSA, antibiotics, it could be Keflex, correct? Cephalaxin, you guys learned this already? You guys did antibiotics already, right? But the important thing to understand is that I need to know that you guys know that when it comes to cats and dogs, you have to cover for pastorella multicida. And if you don't, the patient will need surgery, potentially, right? Especially if they're cats, right? Cat bites. Okay, not the patients, the wounds are cat bites, right? So I need to know that you know that. Okay, so that was the purpose of that question was, hey, do you understand what the things are that you need to be treating for and covering for? Make sense? So that's again, another higher level form of reasoning and thinking that you guys understand that, hey, I need to make sure that my antibiotic selection is appropriate for the wound that presents, for the injury type. Make sense? Okay, are we all good with that? Okay, so again, I'm not trying to trick you. I'm just trying to, again, verify the knowledge, right? I only had 7 periods of instruction with you guys. 7. Think about that. And then we'll move on to lower extremity. So I need to make sure we're hitting milestones. Because if we're not, right, and the question didn't perform well, yeah, I give you the question back, but it performed well. But we need to slow down and go back, and we need to talk about these things. Because then when you get into ER, into emergency medicine next semester, and you're talking about people presenting with those injuries in the emergency room setting, they need to know that you know these things too. So the sooner you learn it, the more you understand, hey, I need to know this. Are we good with that? So again, nothing, we like to say in surgery, we like to say no wasted motion. Right? So I don't try to trick you guys. I just try to emphasize things and then see, did we get it? Okay? She's looking at the schedule. So, yeah. I'm just trying to figure out when I'm going to stop talking. All right, so I've gone on for about 12 minutes now about the test. Again, I think it's a valid test, okay? I think it's a fair test. And I think that the performance speaks for itself. And again, people are saying, hey, you need to make it harder. People, you know those people, those two dudes. Those two dudes are responsible for 95% of things, right? Yeah, I got jumped by those two dudes, or those two dudes did this to me, right? Those two dudes. So, and I don't feel that's the case, okay? So you can anticipate, or you can expect, excuse me, that I won't switch things up. I'm going to stay consistent, and I'm going to teach you guys and test you guys the same way in block 3 as I did in block 2. Okay? And then guess what? You guys get to reset and figure a whole other person out. Because for block 4, it's going to be Colonel Sylvester. Okay? He's a very experienced senior orthopedic surgery kid himself, and he has a lot of knowledge. Okay? So I'm going to stop talking about the test and block 2, and we're going to move into block 3. Are we good? Okay, so block 3. Yes, ma'am. I almost got through. Yeah.
So are you planning on submitting a more updated slide?
I am. So on that note, I was out dealing with a family emergency, okay? And I lost Canvas access simultaneously. So I do have the new slide deck updated. I just cannot get into Canvas to upload it. Okay? So I apologize for that. Again, I don't mean to be that guy, but I don't have a choice. I called the IT support center. I was on the phone until 12:16 this morning. Okay? And they said, it's not a government thing. They're like, oh, we'll submit a trouble ticket and we'll work on it. I'm like, really? Like, I was supposed to lecture at 10. Oh yeah, they don't come in until 8. Right? Then I called them this morning and they say, well, we'll get to it. Okay? So I was like, well, I'm used to that, right? We're all military in here. Okay, so I apologize for that. So to answer the question, it will be uploaded as soon as I actually get access to Canvas, okay? So how do I have the slide deck up now? Well, Colonel Sylvester emailed it to me on my personal email, and I downloaded it. So we make shit happen, excuse me. There you go, first curse word for the semester. So we're gonna make things happen, okay? And that's what we're doing, right? Good to go? But your concern is valid, and I apologize for that. Okay, I don't mean to waste your time. I know you guys like to look ahead. Again, we'll work the issue and ASAP, right? It'll be updated and we'll move on, okay? Any other concerns? Lab this semester, this block, excuse me, will be the same as the last block. You guys like doing the lab with me? Yes. Okay, we'll do it the same way, okay? The lab assignment, I should say, will be done that way, and then the lab itself will be the same. We will demo this stuff, then we will practice, and then we will talk about it, and then we'll demo some more if we need to be. Okay? Good to go? Okay, you all have any concerns? Okay, we're going to move on. Welcome to block 3. So we're going to be talking about lower extremity pathology. So we're going to start today with review of imaging. Okay, so lower extremity musculoskeletal radiology. All right, because it seems like it was so long ago when you guys had radiology, right? And you talked about x-rays and things like that, but what I need to know specifically is that if I give you guys radiograph or radiographic findings, that you understand the correlation between the pathology topics that we're discussing and the actual imaging that is either being referenced or is being provided for you. Okay? Same as before, going back to what I was saying about testing in the future. If I give you a radiology image, it will usually be supported by the question and not be vice versa. What does that mean? You could literally answer the question if you didn't have the image. Okay, but a couple of them, if you know the image too, it's like, oh yeah, that's what it is. Right? Make sense? Now, the exception to that, obviously, if it's a picture of a physical exam, you gotta have the image in, right? So, all right. Lower extremity, what are we gonna talk about? Introduction, you've been introduced. So we're gonna talk hip joint, femur, knee joint, leg, ankle joint, and foot. A little bit of a caveat to ankle joint and foot. This is the lower extremity block, but we'll end about the ankle. The reason I cover the ankle and the foot in this block though is that you guys have a primer then going into block 4. Make sense? That way you're not just jumping around. Okay? But we'll end at the distal tibia in this block, and we'll pick it up again in the ankle joint and below in the next block. Okay? Good to go? So you should get some reinforcement then with the ankle and the foot stuff in the next block. Don't get too nervous about ankle and foot for now, because again, that's what block 4 is for. 4 is for? 44? All right, so review of bony anatomy. So we know the hip joint is a joint that has a great amount of articulation, correct? Okay, so when we talk about the hip joint, a couple of things that we talk about, again, different anatomy. We talk about the ASIS, the anterior superior iliac spine, okay, as it relates to the hip, and then we talk about the hip joint as it articulates. When we talk about hip pathology, what's the usual thing that's patients have issues with hip pathology? Internal rotation, okay? So they have a lot of pain with internal rotation. So think about it as opposite. So if somebody has painful internal rotation, then they'll be walking in external rotation. Does that make sense? You guys will hear that again soon, okay? But just understanding, if you look at this picture, you're like, okay, well, this is a normal anatomic position, right? Toes forward, okay, or anterior, pointing towards you, okay? Moving down, we talk about the femur, then we get to the knee joint itself, then we get into 2 bony structures, the tibia and the fibula. There's no such thing as the tibula, it doesn't exist. Please don't say that. Okay. All right, doesn't exist. And then obviously the ankle joint, which is a weight-bearing surface, correct? Yeah. Okay. And then moving down, when we get into the feet, we talk about the tarsus, the metatarsus, and the phalanges. Again, not the carpal metacarpal, but the tarsal metatarsal. Okay, so start thinking about things in your mind as we transition into lower extremity to not be using the word carpus anymore. Good to go? And we'll break this down a little bit more. The patella, right? The patella is a sesamoid bone that is anterior to the femur, correct? The distal femur. Okay? I missed that. Patella always gets left out. All right, so hip joint. So this is a hip joint that's been dissected and reflected, meaning it's been externally rotated, if you will, to show you the actual articulation surface, and that is acetabulum, correct? So acetabulum has a labrum, right? So similar to the shoulder joint, the hip joint the acetabulum has a labrum, okay? So that acetabular depression there, we talked about the glenoid fossa. Now we talk about the acetabular fossa, right? So again, that's the cup that the ball fits into. Make sense? So terminology-wise, again, make sure we're talking about the same thing here, because we don't use terms like glenoid anymore, okay? So when we talk about all these obturator arteries, obturator membranes, things like that, on the bottom there and the bottom there, I don't really get into that deep, okay? But you do understand that iliopsoas tendon, right, belly, goes through and crosses the hip joint, correct? So when you guys talk about abdominal concerns, right, remember you can do that resisted straight leg raise. Okay, so again, when I talk about that resisted straight leg raise that we'll talk a little bit more about when we talk about physical exams, I am centering in on the effect that that test has in assessing for intra-articular hip pathology. Make sense? And usually when we're talking about that, it's the good old osteoarthritis and it's the good old labral tears. Okay? Make sense? So do we look here in this picture and we can see that the head of the femur has that shiny surface there? Do you think that's cartilage? Okay, again, and if you look at the shiny surface of the acetabular, is that cartilage? Okay, so you can have osteoarthritis that affects both sides, right? And so we'll talk a little bit more about that as we progress through the lecture. Any questions about this bony anatomy? This is just a general brief overview to give you guys a little refresher. Again, if you know all the arteries and the ligaments themselves, that's great because you understand, hey, if you have certain pathology, this is what's involved. But don't worry, as we get specifically into dedicated topics, then I'll let you know, hey, you need to know these structures. What arteries are involved, what ligaments are involved, etc. Okay? We go with that? So don't be one of those people who just memorize this picture because I don't like coloring pictures, right? I already have enough on my fridge. Okay? So now we move into the radiograph. So again, we use that terminology A and P, right? So this is a normal hip radiograph AP. Yes, some of you guys know that when it comes to hips, we do all kinds of imaging potentially. We'll talk specifically about different pathologies and the imaging that may be specific to those. But in general, in AP here, remember how we talked about the greater trope and the lesser trope? Okay? So that's, the word is trochanter, right? Greater trochanter, not greater tubercle. So again, in your mind, make that transition. It's the greater trochanter, so right there, correct? Right, and right there, okay? And the lesser trochanter, which is right there and right there. So just similar to shoulder and proximal humerus views, the greater trochanter in the normal AP should be lateral, correct? So that's how you know if you have a good AP image. And the lesser trochanter should be medial. Pause. We good with that? Concept is the same, but the terminology is different. Okay? So again, discussion-wise, when we talk about different parts of the pelvis itself, we do understand that there's the ilium is the superior crest, right? So right there, crest of the ilium. So that's that portion of the bone right there. And then as we move down into this area here, that's the ischium, right? And right there. Okay, so make sure you understand like what part of the bone, or the pelvis, excuse me, and the hip that we're talking about. That way you don't get those things confused when I give potentially those descriptions on a test question. Make sense? And more importantly, when you're talking about pants questions, right? This will end someday, and hopefully pants will too, right? And then every 10 years, like I'm going through right now. So then, let me move down to the femur itself. So the femoral head, right? Femoral head right there. So that's pretty straightforward, okay? But the femoral neck is something we're going to focus on with some specific pathology. So if you look at this femoral neck here, right? At least on this side, okay, you see that nice curvature right there? Okay, so that's a normal AP. So when you start looking at a normal AP and you say, okay, there's a normal head-neck junction curvature, that's what it looks like. Okay, that's exactly what we're talking about. Okay, so when we talk about head-neck, it's literally the head, and this is the neck right here. Okay, this is the neck right here. So does femoral neck fractures occur? Yes. Okay, and so does, like Mr. Brown just said, intertrochanter fractures and intertrochanteric fractures. So where do you think those fractures are? Between the trochanters, right? Makes sense? So you can have a head-neck or a neck fracture and or a intertrochanteric fracture of the femur. Do you think those are significant?
Yes.
And those are significant because if you see those on x-ray, do you think you need to make your patient non-weight bearing?
Yes.
100%, because if they're incomplete fractures, right, when we start talking about stress fractures, stress injuries, then you're like, okay, depending on where the fracture is, they're at risk for potentially complete fracture, bless you. And so you need to take the appropriate steps. That's why it's important, again, for you guys to understand that when you're talking about hip pathology, when you see things, you need to know how to respond to those things in the interim until you get ortho on the phone or you disposition the patient. Okay? Make sense? Are we good with this anatomy? Okay? Yes? Oh, okay, we're gonna move on. So this is a frog leg view of the hip. Okay, more commonly the frog leg is, and we'll talk about pediatric topics, but it's more commonly done for pediatric patients. But if you do get a frog leg view, this is what it's gonna look like. Do you think that the leg is extended laterally here? Yeah, the leg is right about here in this picture, okay? And right about, oh, sorry, over here somewhere in this picture, okay? So when you're looking there, can you see a better definition of the head neck in this view? You can.
Yeah.
So again, if there's a question about whether or not there's a neck fracture, okay, or some kind of pathology in the head-neck junction region, we'll often get these kind of views, okay? And that can help you better discern, do I really see that? Because if you see it on the AP, right, it meaning a potential fracture or some kind of bony abnormality, and then you'll also see it on the frog leg lateral view. Is it real? It's real, okay, and that's kind of it. So again, getting back to that principle of orthopedics, when you talk about getting radiographs, one view is no view, right? So orthogonal or 90-90 views, if you will, that's what we call them, is basically looking at things from different angles or different projections to make sure that you can assess for the pathology. Okay, where's the lesser trope? Right about there, and right about there. Okay, so therefore the greater trope has to be somewhere else, right? And where is that? Can you guys see the greater trochanter there in that picture?
Yes.
Okay, so again, when you look at this and you're saying that the patient, it looks like there's an injury to the trochanter, which one is it? So I do want you guys to kind of zero in on which one is the lesser and the greater and what position they are in based on whether it's a frog leg lateral view or an AP radiograph. Here you go. Okay. So this again is another normal radiograph of a lateral view. It's not a frog leg lateral view, okay? But you can see some more definition there. Okay? And again, where's the lesser trochanter? It's labeled. Okay, so you can see that there. Okay, versus the greater trochanter. Is the greater trochanter a little bit more difficult to see in this picture?
Yes.
In this image? Yes, it is. Okay, so again, one view is no view. Okay, so the acetabulum can still be seen there, and the head of the femur, the femoral head. Okay, so acetabulum here and the femoral head here. So you can see that relationship because again, the ball should sit in the cup, right? So, but there's also a relationship that you're looking for as far as this portion here of the acetabulum. Does it cover the head of the femur? This portion of the acetabulum here, does it cover the head of the femur? Or is there what's called bony overgrowth or over coverage? Okay, and we'll get into a little bit more when we talk about pathology for MSK, for lower extremity pathology. Okay. So usually for a lateral view, so in a non-trauma situation, they literally will roll their leg outwards and put the plate underneath their leg. Okay, so everybody sees what I'm doing right now? So kind of roll outwards and put the plate underneath. Okay, so again, a frog leg, and don't make fun of me, okay? I'll grip the podium just to make sure I don't do something. But a frog leg is literally, you guys know what a frog is, right? Does anybody here not know what a frog is? Okay. And Julia, of course, right? So I'll talk a little slower. But a frog leg is just like this, okay? All right, so literally it's a frog, okay? That has its leg upwards and outwards, if you will, okay? So flexed and externally rotated, okay? I wasn't on camera, was it? Yeah. Okay, good. So a normal CT scan, you see everything you need to see here, right? No, this is just one slice. But you would agree that you can see a better definition of the bony landmarks there. You can also see a better definition of the bone morphology and the relationship, to some extent, of the femoral head and the acetabulum. Okay? So, I don't think it's fair, well, unless somebody wants a question on it, to give you a CT slice, right? Because I have to give you like 315 slices for you guys to really discern this. But just understand that when we talk about intra-articular pathology, didn't we talk about in block 1 that a lot of times if we're questioning intra-articular pathology, that's not necessarily soft tissue, that we'll get radiographs and CT scans? Yes. The answer is yes. Okay. So again, if you get the views, AP and lateral radiographs of the hip itself, right, and you're thinking to yourself, I still don't quite see it, but I think there's some kind of pathology involving those bony landmarks that we talked about, right? Whether it be the head-neck junction, whether it be intertrochanteric, the CT scan can give you a better sense of that. Okay, so it's not uncommon for us to get these. Do we get, some people call them pan scans, but do we get abdominal pelvic CT scans in trauma?
Yes.
All the time. So we can also, in ortho, we can look at that and say, well, not really looking at the soft squishy things, but I'm looking at the bony structures, okay? So if some of you guys can go on to move into emergency medicine, you will become adept at not only looking for the soft squishy things, but also looking at the hip joint and to see whether or not there's any kind of femoral neck, femoral head, acetabular components, okay? But we can also get dedicated CT scans for the pelvis, correct? Okay, so there's a question about a pelvic fracture, then we can get those as well. Or depending on the level of imaging they do for trauma, we can use that imaging to look at that. Does that make sense? Okay. All right. So here, again, that is an MRI. Well, that is the label wrong, so apologize for that. So but an MRI image, do you think this relationship that you're seeing here, is that a coronal, axial, sagittal? What plane are we looking at? Coronal? Axial? Okay, I agree with you. Okay, so when you're looking down the barrel, if you will, and you're looking for that relationship there, you see what the better definition you get there of the acetabulum and the cup? Okay? So when we're looking at this here, we can also get a sense of pelvic fractures, but not just necessarily of the acetabulum and the femur. You see where that white arrow is there? So is that the pubic rami? Inferior rami? Yes. Okay, so that's what they're pointing out there. Okay, make sense? Okay. This is actually, I'm sorry, this is a fat saturated CT image. So this is going to throw you off. And this is why I don't like this slide and I'll take it out. Is that you can get, believe it or not, if patients are, there are some patients that can't go undergo MRI?
Yes.
Yes, right, because of metal, etc. So old salty war veterans with a ton of brass inside them. Okay, so you can get actual CT imaging that they can reformat it and to give you a better definition of some soft tissue things, but it's still not as good as an MRI. Okay, good to go? Don't focus too much on that. But an MRI, this is what I consider the gold standard, or is considered, excuse me, the gold standard for any kind of intra-articular hip pathology that's not necessarily of traumatic nature, and that you're suspecting potentially that the patient has some kind of intra-articular pathology as it relates to what? Labral tears, right? Yeah? Can you also see muscle bellies? Yes. Can you see the psoas muscle as you slice through it?
Yes.
Yes, you can. So again, this is a very useful image. It can also show you bony activity, right? So the metabolism, bone metabolism, so you can see areas of avascularity. You can see areas of increased signal. So if you see an area of focal osteopenia and you're suspecting osteonecrosis versus osteomyelitis, can that be helpful? Yes. 100%. So the focal osteopenia relates to which one? Is that osteonecrosis or osteomyelitis? Get it right, get it right, get it right. Osteomyelitis? Yes? Angela says yes, so you all have to say yes too. Okay? Because avascularity looks different, right? Avascularity or avascular necrosis is literally bone death due to lack of blood flow or bony blood flow. Okay? Make sense? And we'll talk about that a little bit more. Any questions about MRIs and why we get them versus CT scans? I think that it is important to understand this concept. Okay? Alright, so we were just talking about hip, right? So if we get into femur, do you think that if you are looking at femoral fractures, that you might get a hip view, right? A joint above and below. But what if it's a long bone? Is the femur a long bone? Yes. And you want to get a joint above and below, so you would get, if it's a femur fracture, you would get the hip, you would get the femur, obviously, and then you would get the knee joint, correct? Okay, but let's talk about femur specifically. So when we talk about the femur, right, we're already about the head, the femoral neck, the greater trove, but then we also talk about the shaft, or the diaphysis, correct? We know what the diaphysis is, right? The long center, okay? So then we go down deep, distally, and we move down to the lateral condyle and the medial condyles, okay? Remember, you see the terminology here, lateral, medial condyle, right? When we talk about condyles, there is no epicondyle, correct? We're just talking about condyles. So those are the big bony protuberances, both medial and lateral, depending on what side you're looking at, okay? Are we good with this? Okay, am I going to ask you about all the bony attachments for origins and insertions of all the muscle groups? I can if you want me to, but I'm not. But just understand when we talk about specific pathology, I may tell you, hey, based on the fractures to this area, why is the patient having difficulty with hip adduction versus abduction? Make sense? So that's why I briefly introduced that today. Okay, so looking at radiographs for the femur, okay, normal AP radiograph. Again, is this a hip view or a femur view? Femur view, right? Make sure my watch is right. So if this is a view of the femur, you would agree that the femur is a long bone, correct? Yes. So a lot of times we can't get the femur on one plate, okay? So is it fair, right, and very often done, to get a view proximal femur and distal femur? Yes. Yeah, and that's what you guys are looking at there, okay? So why do I say that? So if you come to me, right, and you say, I got a hip x-ray, this patient has a diaphyseal femur fracture, I'm like, great. Did you get a femur view? Say, no, I can see the fracture in the view. I'm going to get so sad, right? Because you didn't get the entire femur. Do you think patients that have both proximal femur and distal femur pathology are treated differently? Yeah. Yeah, there could be a difference between a nail or a plate and screws. We won't get into the surgery stuff, but I'm just telling you, I'm going to be sad. Okay? Because I'm like, I just don't get it. I need to know. My x-ray vision doesn't work. I've been trying to work on it for 20 plus years and it's still not working. So I gotta be able to see these. Okay? Are we good with this? We understand again the definition of the greater trove and the lesser, I keep saying trove, so that's how we talk, right? Greater trochanter versus the lesser trochanter. The lesser trochanter is medial and the greater trochanter is lateral. I've said this so many times now. Don't worry, somebody will get it wrong. Yeah, that's a joke, sort of. So can you get a lateral view as well? Absolutely, right? So is a lateral femur view the same thing as a lateral hip view? No. Again, you see how the center of the focus in this view here is the femur itself and not the hip, right? That image right there, okay? And the image on the right side is a lateral, correct? You can't even see that hip in that lateral view there. Can you? No, you cannot, okay? So how do I know this is a good lateral? This is a decent lateral, I would say. So you see the condyles, right? The medial and lateral femoral condyles on that view and on this view here, they should overlap. Okay, so we do use this terminology. It's not derogatory, but it should not be a double butt sign. Okay, they should literally overlap as much as possible. That way they're on top of each other. Okay, and you can't discern really which one's lateral and which one's medial. This is a decent one though, and it tells us what we need to see. Because we can also, for a certain extent, we can see the undersurface of the patella as well. You see that there? Okay. Now, do we get knee views to get a better look at the undersurface of the patella? Yes. 100%. But in a pinch, especially in a trauma situation, this can be useful. Okay. Make sense? Okay. Any questions about this? Okay. Let us. Should we? Yes? Some people have fallen out. Let's stop, take 10 minutes, and we'll start, then we'll finish up with your orthopedic rotation. Don't worry, I'll get feedback. And oh my God, they said that was to teach me anything. Yeah, I'll find you. But to make sure that you take the opportunity, if you can, right, to be on call. Do you think you're going to see a lot of hand lacerations on call? Yes. Do you think that'll make you more comfortable when you're out there in the clinic by yourself?
Yes.
Right? Then you get what's called the who, me syndrome, right? You're out there by yourself. And when I look at my OSCE, when you come through the OSCE and I say, hey, what do you think, what do you want to do? Sumo Jack? Was that close? Okay, all right, see, I've been practicing. They say, well, what do you want to do, Mr. Tibbet? So then he looks at me and he says, who, me?
Oh, yeah.
You do understand this is where it's heading, right? When you guys get out there and you're out by yourself, your comfort level will be directly related to your stress level. So again, when you guys are out there rotation, stay calm, do every injection you can, right? Do every procedure you can. That way you get a little bit more comfortable, okay? Grand total. All right, so getting back into it. So now we're gonna talk about my favorite. I love knees. I love it, I love it, I love it. This sports medicine, I was at the Air Force Academy, we're the chief of sports medicine for the Air Force. And so we took care of NCAA athletes. A lot of knee injuries, right? Football injuries, lacrosse, soccer, right? A lot of knee injuries. Are you guys going to see a ton of knee injuries? Tons, okay? So your knowledge of anatomy is going to be super important. Okay, so when we talk about the knee joint, again, we talked already about knee osteoarthritis in some sense, but you do understand that the bony surfaces both of the distal femur and the proximal tibia have cartilage, correct? But guess what? They also have menisci. Okay, so the meniscus, right? So either the lateral or medial meniscus, as highlighted in these pictures here, right? Those are the shock absorbers, if you will, and they also provide lubrication. So that basically shock absorbers for that impact that the patient takes as they're running, jumping, making a crash landing from the sky with a parachute on, things like that, okay? So it's important to understand that relationship there. Then when we talk about the collateral ligaments, you guys remember when you guys pretended like you knew how to do the 0 and 30 degrees, varus and valgus stress? Okay, those come into play, right? But guess what? You're in orthopedics now. So you do understand, you're in orthopedic course, excuse me. So you do understand that the medial collateral ligament attaches to the distal condyle of the femur and the proximal condyle of the tibia. So terminology is important. Because then when we talk about the lateral collateral ligament, what does it show there? The lateral collateral ligament proximally attaches at the distal femoral condyle, but it does not attach to the distal tibial condyle. What does it attach to? The fibula, right? So then if you understand that relationship, then you understand if you see a proximal fibular fracture, how things may be affected. Make sense? So this is why, again, your anatomy is super important that you guys understand this. Your knowledge of anatomy is power. Okay? Good to go? Is there a lot of articular cartilage in the distal femur? Look at that. That's a lot, right? When we go there and we replace that femur, we just hack the whole thing. Okay? For what? An arthroplasty, correct? We just take all that away. And the menisci and all that stuff. We just make it all new. Okay, but you see how much cartilage is there, right? Do you think that looking at that picture that the surface of the cartilage that may make impact with the proximal tibia may be different based on whether the patient's knee is extended versus flexed? Yes. So if you look at this picture here, you understand that the way your patient reports their symptoms, right, can relate to the pathology. I have more pain in a bent knee position, or I have more pain rising from a seated position. Make sense? Okay, moving on. I'm sorry. So what's that? ACL, right? So anterior collateral ligament. All right. So you understand the ACL attaches to which wall of the intercondylar groove of the femur. Ooh, he's making me think, right? So you would agree that cruciate means across, right? So the anterior cruciate ligament attaches to the medial wall of that groove. You see that? So it goes from lateral, right? How do you know you're lateral? Because this is the fibula, right? Right, not the femur, not some other word. Okay, so we'll talk a little bit more about that. I just want to get you guys thinking about that. So therefore, if it's a cruciate, it's a cross, then the PCL attaches in the opposite orientation. Would that make sense? Okay, so again, why am I saying this now? Not because it's the only time I'm going to talk about it, but just to get you guys to understand that, again, based on whether a patient's in a flex knee or an extended knee position, they can have different levels of instability. Aha! So that's why we do testing in different positions, right? Don't we test the ACL in the anterior drawer in the 90-degree position? Okay, and that's the reason why. We'll get into that, okay? Good to go? So normally a radiograph. Okay, I shouldn't have to label this radiograph. You should know whether this is right or left, right? I wouldn't do that to you. But you should know, because the fibula, not the tibula, right? The tibula doesn't exist. The fibula is lateral, correct?
Yes.
Okay. So when we're looking at that relationship, again, we're looking at the lateral femoral condyle and the lateral tibial condyle. And the way I described it before is how I describe it on potentially a question, right? But just understand that the lateral tibial condyle is the distal femur, and the lateral fibular condyle is the distal femur, and the lateral tibial condyle is proximal. Make sense? Don't get those two confused, please. Okay. And vice versa on the other side. So that intercondylar notch I was just describing, that's literally that notch right there. Okay, that's that notch where, again, and right there, where the ACL attaches to the lateral wall. Okay, and we'll talk about that some more. Why is that important? If you see a little bone fleck there on this x-ray that looks like something got pulled off, do you think that could be where the ACL attaches right there? And right there? And so you may suspect it. Same thing with the, everybody understands this is the tibial spine, right, as we call it? Okay? Everybody heard that term, tibial spine? So right there, that's the tibial spine. So if you see a little piece of bone pulled off there, but it wasn't necessarily an ACL injury, but it's a fracture that's in that area, do you think we treated the same thing as we would as if though it was a pseudo ACL injury? 100%, because you know that the ACL attaches there, right? So as long as the bone stalks in, it's not detached from that bone that pulls off. But as long as the bone stalks in, they should have relative stability once that injury heals. Too much? Maybe. But we'll get into a little bit more later, okay? So don't get too worried about that just yet. I'm just trying to get you to think. I know, that sucks. Okay, so when we look here, you see the lateral and medial condyles of the distal femur, the lateral and medial condyle of the distal femur, how they overlap. That's a lateral view. So how do I know it's a good lateral? Well, A, the knee is in approximately 30 degrees of flexion, okay? Would you agree this is approximately 30 degrees?
Yeah.
And the condyles overlap, okay? Everybody sees how you can see a little bit of kind of this sense that you can make out one condyle versus the other, but for the most part they overlap. So you don't have what we call the double butt sign, where it's not going to be lateral, okay? Do you think it's important to get good laterals?
Yes.
Yes, because can you see the undersurface, the articular surface, I should say, of the patella as well, if it's not a true lateral? No. Can you see certain relationships? No. Okay? Well, we'll get too much into that again, because when I look at X-ray, I see a lot. I'm trying to gauge a lot of things, angles, measurements, things like that. Okay? All I want you to understand is, okay, looking at the image, it's supposed to be a lateral. The condyles overlap. I think I got a good lateral. It's in the knees bent in 30 degrees. We're good. Tibial tuberosity, what attaches there? Patellar tendon. Ligament. Okay. All right. Patellar tendon. Okay. Okay? Too early? Too late? Okay. So this is called a sunrise view. Why? Because you're shooting right down underneath, right? So when you're looking at this relationship there, obviously the patella as it's labeled, you can see the articular surface, correct? Can you see the cartilage? No. But if you see areas where there seems to be defects, right, or abnormal contours, etc., then you can suspect that there may be some kind of pathology underneath the kneecap. Okay? Well, that's known as patella. Okay? Can you make out the lateral and the medial-femoral condyle? Yes. You see that groove that it sits into right here? Okay? So that's that normal relationship, correct? So you would agree that it looks like that patella fits into that groove, almost like a puzzle piece, correct?
Yes.
But if there's pathology that we'll talk about where that groove, right here and right here, is very shallow, meaning it's not deep like that, it doesn't allow the patella to sit into there well, that they could have patellar instability?
Yes.
Yes, so we'll talk about that, okay? Am I gonna ask you on a radiograph which one is the lateral and which one's the medial with nothing labeled? Only Angela, because he got too excited. Okay? All right? But the answer is no. But you would agree that if you look at this, that angle seems to be in a certain orientation so that you can discern which side is which. Okay? Good to go? Okay, so normal MRI of the knee, great. This tells me nothing. But you do agree that this is an MRI, right? So, all right, you see on the bone in this particular, you guys talked about T1 and T2 weighted and all that stuff. Okay, you pretend like you knew what it was and then you moved on. Okay, so understanding that if you get T1 weighted, that certain things that are white look a certain way, and certain things that are not supposed to be white look a certain way, and vice versa when you get T2 weighted images. T2 tends to be more for soft imaging, soft tissue imaging, excuse me, and then T1 tends to be more for looking at bone. Okay, so you would agree that this is a T1, right? Of course you do. Okay? Don't get too focused on that, just understand that MRIs play a huge part because this is the view I look at. You see how the bone looks white here? It looks like bone, right?
Yeah.
So what am I looking at? It's labeled. This is a sagittal cut of an MRI, correct? Can you see the ACL there?
Yes.
Yes. Okay, and you can see that when you look at the ACL, and this is a really good slice actually, and then you can see the PCL behind it. Can you kind of imagine in your mind that the PCL, if it keeps going, it's going to cross the ACL? Okay. So again, anterior, posterior cruciate ligaments. Okay? What kind of damage are we looking at? Housekeeping. Okay, and then we can also get a sense of the patella tendon. That's the P, right? Here and here, correct? Oh, by the way, what's this tendon up here? Quadriceps. That's a quad tendon, right? So we look at quad ruptures as well, quad tears. And we'll talk about that, okay? But I'm just trying to get you guys to think. When you look here at the ACL slide image, this is actually a really good image. Would you agree that all the fibers of that ligament appear to go in the same orientation?
Yes.
Right there, right there. So if you look at that, it doesn't look clean and smooth, right? And it looks abnormal, meaning fraying, right? We talked about the term fraying. You would agree that that could denote that the patient has some kind of fraying or partial tear, right? Or maybe a chronic tear versus a complete rupture. If you see no relationship there, do you think that that means that they have a complete ACL rupture?
Yes.
Well, yes, but that coupled with your physical exam, correct? We treat people, not MRIs, right? You'll hear that again. Okay, good to go? So, this is where I start talking about, like, you see that groove in there, right? Or that notch, excuse me, the notch in there.
Mm-hmm.
Okay, if you can imagine slicing through that, this is an axial view, correct?
Yes.
Yes, okay, good. Just want to make sure we're still awake. All right, so that's axial. So if you were to slice through there, would you agree that you can look at that groove, or that notch, I keep saying it, that notch, and you can look at that wall and see whether or not the ACL attaches there versus the PCL where it's supposed to attach? Yes. So another useful example, okay? Can you also see the menisci as you slice through it? Yes. So again, you can discern some meniscal pathology. And we'll talk more about meniscus. That needs its own dedicated lecture for it. Questions about general knee anatomy versus MSK radiology. Now we're going to speed up a little bit, okay? Leg stuff, again, we're going to cover more of the proximal and the shin, if you will, right? And then we're gonna move into specific fractures and ankle and foot stuff in block 4. Good to go? So just as a general overview, you understand that you have the tibia, the fibula, right? So you understand that when you're talking about the ankle joint is actually formed by components of the distal tibia and the distal fibula. Would you agree?
Yes.
Okay, so when you talk about a distal fibular fracture, you would agree that by definition, therefore it involves the ankle joint. Okay, so we're good with that?
Yes.
Okay, good. And you would agree that the end of the fibula is on the proximal end or the distal end?
Proximal.
Proximal, right? So kind of like we think about when we talk about proximal radius fractures. So the head of the radius. So same concept here. So make sure you understand, if you're talking about lateral malleolus, which is the lateral end, distal end of the distal end of the fibula, right? Distal end of the fibula there, then you're actually talking about the lateral malleolus, correct? And then on the opposite side, you have the medial malleolus. You see that there? And that there, okay? What's not shown here, do you have the posterior malleolus as well? The answer is yes. Okay, so understand when we start talking about these different structures, when I'm using the word malleolus, you're thinking more distal and potentially ankle joint involvement, correct? If I'm talking about head of the fibula and proximal tibia, you're talking more of the knee joint itself. Good to go? There is none. No, posterior malleolus. We'll get into that slide here. So it's better seen on X-ray. Okay, so when we go, he was asking about where's the posterior malleolus. I'll show you in a second. So when we're talking about X-rays, then we take that knowledge of anatomy and we translate that to what should be apparent to us on the radiograph, correct? So you would agree that when you're looking at this view here, this is an AP radiograph, right? Do they always have to be straight up and down? No. Can you, in the system, rotate it so it's rotated 45 degrees? Yes. So you need to look at it straight up and down, great. But you guys do see the overlap of the distal fibula and the distal tibia,
Yes.
right? You guys see that overlap there? Right, so can you see the ankle joint clearly? No. So does that mean that there's going to be another view where you can see the ankle joint more clearly?
Yes.
Yes, we'll talk about that here in a second. But looking at this view here, this is a leg view though, correct? So do you think if you suspect that there is a proximal fibular head fracture, remember we talked about joint above and below. So this is zoomed in on the leg, right? The tibia and the fibula, correct?
Mm-hmm.
And if you need to get multiple views to get the entire span of the bones in view, then you do that. But understanding that if you are suspecting ankle joint pathology, that you have to get ankle views as well. You good? Okay, you guys are going to talk about Massenou fractures, okay, in block 4, right? And then if you see a proximal fracture of the fibular head, right, or fracture of proximal fibula, then you're going to get ankle radiographs, and we'll talk about why. We'll talk about why you have to get them, essentially, because you're going to miss the treatment for it, right? And you're going to make me sad if you call me on the phone. Okay? So on this view here, so you would agree that if this is the medial mal, that means you're looking at the medial aspect of the ankle, right? Makes sense here? Okay, so this bony projection here, is that the posterior mal? The answer is yes. And this bony projection here? Oh, you guys see that? Shaky. I gotta drink more coffee, or less coffee. All right, so posterior mal. So if you have, if you get a radiograph report, right, from a radiologist, you read it and said it's a trimal fracture, trimalleolar, that means the medial mal, the lateral mal, and the posterior mal are involved. Make sense? Okay. Do you see the double butt sign on the femurs there? Okay. Yes, you do. But that's okay because this is not a knee X-ray, right? This is a leg X-ray, right? Tibia and fibula. So you have to forget that a little bit because you want to get the entire surface of the posterior malleolus in good view. Okay? Good to go? Any questions about this? Okay. That was pretty fast, right? Pretty fast. Don't worry, we'll slow down a little bit in lecture. So ankle joint stuff, again, this is in here just to give you guys a primer. And we're talking about the ankle joint. We just talked about how the ankle joint is actually made up of those different bony structures and bony landmarks. But then you also, there's 3 ligaments I want you guys to know, right? ATFL, CFL, and PTFL, okay? Anterior talofibular ligament, anterior talofibular ligament, so talus, okay, that's a bone, right? And what is the other part of that? Fibula, right? So where do you think the bones connect to? Okay, slow it down, think about it in the exam. Okay? And then you talk about the calcaneofibular ligament, or the CFL. Okay, so calcaneofibular ligament, that means it connects to the calcaneus and the fibula, right? Do you think that's the distal fibula? It is. All right, so it's very simple to think about this term. So then the posterior talofibular ligament, same concept as the ATFL, just posterior, correct? So what are the 3 most common ligaments that are injured in lateral ankle injuries? These 3. This is why you need to know this. Because when you talk about a grade 1, 2, 3, etc., lateral ankle injuries, this is what you're using to classify. Okay, so you're classifying the ankle injury, the severity of the ankle injury based on damage to those 3, or injury, excuse me, to those 3 ligaments. Make sense? So that's why you need to know these 3, okay? You see the Achilles tendon there? Okay. What is the strongest attachment point you have on your body? The Achilles tendon. That's it. Okay. If you look at that picture there, you would agree, I hope, that the Achilles tendon inserts more distally than you thought. Right? You want to just point right to the most superior aspect of the Achilles. How far does it insert? It inserts pretty far down into the calcaneus, right? You see that? Okay, so just understand that. Okay, and we'll get more into that when we talk about Achilles tendon ruptures. Okay, so when we get an ankle radiograph, you would agree it's important to see the relationship between, this is an AP, correct? So the relationship between the distal ends, the distal aspects, of the tibia and fibula, more specifically the medial mal, lateral mal in this view. You have the talus there, okay? And then that relationship there, where's the joint line? It's exactly where it says right there. The joint line is the tibio-talar joint, right? Tibio-talar joint, and right there. My pointer didn't help? Right here. Yeah, my pointer's good enough. All right, so tibio-talar joint. Okay, can you see a good definition of that on the lateral aspect? No. Okay, so then you're going to get this view. This is called a mortise view. Are there anybody here who's a mason or any kind of like concrete work, stuff like that? Okay, but this comes from a mortise, basically is a term in that world where we talk about the surface here. This is the ankle mortise, is this surface here. Okay, is that also sometimes called the talar dome? Yes. Okay. So, but the mortise view is a good view because you rotate the foot to a certain position so you can see that surface of the mortise better. Yes. Okay, so that's why it's important to understand if you're thinking about joint and interarticular pathology, you want to get a mortise view. Don't let that throw you off on testing. Okay, guys. Mortise views are important to discern the relationship between the bony structures and the surface of the mortise, all right, or the talar dome. Do you guys see that little area there that looks like it might be a fracture? You do know that I pointed it out, right? All right, but sometimes we talk about a lateral talar dome injury versus a medial talar dome injury. You guys see where that terminology comes from now? Of course you do. Okay. So this is a lateral view here. So again, you get the relationship of the talus. This is still a talus. But you would agree that there's other joints that are being assessed here too, right? So when we get this view here, you can still make out the lateral and medial malleoli, but you can also see a relationship in those different bones. Okay, so the talus and the navicular. Do you think that joint between the talus and the naviculus is called the talonavicular joint? Yes, so it's important to understand. The other thing you can see is the cuboid, and obviously, like we talked about, the calcaneus. And you can see a certain aspect of the proximal fifth metatarsal. Not metacarpal, right? Metatarsal. You see that area here where it's literally labeled base of the fifth metatarsal? Okay? So if you see a suspicion on these views, because these are ankle views, where you're going to get dedicated foot views to, horse drawing. Right? Normal CT, very helpful, right? But I like this view because you can see that tailored dome better, right? For the mortise. You guys see that? See that mortise there? So again, if there's a suspicion that there may be some bony pathology interarticular, do we sometimes get CT joints? CT scans, excuse me, of joints? We do. And very commonly in trauma, like you guys already learned, right? Okay. Normal CT, very helpful, right? Calcaneal fractures, do you think we get a CT like 100% of the time? We do. All right. Foot stuff, we kind of reviewed this already. But just understand the basic thing I want you guys to transition to now is telling me about tarsals and not carpals. Okay? Proximal fifth metatarsal, does that have its own classification system? Because it's very common injuries? Yes. So that's why it's important to kind of get into that again. When we talk about the phalanges, same rule applies. The number 2 through 5 have how many phalanges? 3. And the hallux, or the great toe, right, has how many? 2, right? So there's an IP joint, not a PIP and a DIP. Make sense? Do you think you can have flexor and extensor tendon injuries in the foot?
Yes.
Same kind of terminology applies, but thankfully, phew, you guys aren't going to get any lacerations, okay? Because the foot is more complicated than the hand when it comes to certain things, but not even because of that. It's just you guys understand by now that it's important to do what? To make sure you isolate when you're testing. Okay, makes sense? So am I going to ask you these bones? At some point, are you going to be asked, I should say, these bones? Absolutely. So understand, the talus is the main weight-bearing surface, right? Then directly articulating with that is the navicular. So the only one you have to figure out from there is which is the cuboid and how many cuneiform are there? 3. Right? So medial, middle, lateral, would you agree? Intermediate, sometimes it's called. It has this label there. So that's something you need to look at. Okay, guys? Make sense? So if I tell you, let me get this picture to be fair. So if I tell you somebody has an navicular fracture, are we usually talking about the medial or the lateral aspect of the foot?
Medial.
Medial, would you agree? Okay. So that's an example of, if you don't know your anatomy, you're going to say cuboid. Which side is the cuboid on? Lateral, right?
Yes.
Okay. Are we good with that little review? Of course it's a review. You guys already knew this, right? Of course you did. And so there's the x-ray that shows all that. Okay? You see how the x-ray definitely shows you distal and proximal of the foot? So again, if you're suspecting a foot injury, you're going to get dedicated foot films. Please. Okay. Good with that? And that one there, that's an oblique view. So everybody knows what the term oblique means, right? So where most often will we see a lot of kind of occult or hidden, if you will, fractures on the oblique view. If you suspect it on the AP or the lateral, and you definitely see it on the oblique, is it real?
Yes.
Yes. Okay. Again, sesamoid bones. Okay. You guys know about this turf toe and sesamoiditis and all this stuff you hear about with football players and basketball players. We'll get into that more. Just understand where those things are found, and that you understand the sesamoids are normal, right? There's an S in there, right? So you can have multiple bones there, right? So if you see 2 bones and you're thinking it's a fracture, could it be normal?
Yes.
Yes, so you need to know what normal looks like. We'll get into that. Okay. Normal CT, of course, this is helpful, right? Normal MRI, foot MRIs, whoo, they're complicated. Same thing with ankle MRIs, right? So I don't expect you guys will be reading too much of those initially, but again, it's a learned art form. Okay, there's a lot going on in a very small area. Okay, normal MRI, sure. Can you guys see the Achilles tendon right there? And right there? Okay, nice big tendon. And do we get MRIs for Achilles tendon ruptures?
Yes.
Okay. So it's important to understand that. That's all I got for you guys today. What, before you guys go, what questions do you have? We finished a little early. So, no questions? You just want to go? Okay. So when we meet next on Tuesday?